We're going to get started since you all were kind enough to be here on time. Everybody ready for the great debate? We'll give you just another minute or two before we close down the voting, so get your vote in. I'm Bill Brown with Brookings Mountain West. Thank you all for coming out. This night has been a long time in planning and thinking, and we're happy to have you here. We hope this is merely the inaugural event. We'd love to make this a regular event. With that in mind, let me say a few thank yous. One, of course, to our debaters, both from Brookings Institution and from the UNLV Debate Team. Any debate team members in the audience by any chance? How about a debate team fans in the audience? Yeah, just a few? Any Brookings Institution fans in the audience? I just have to. Wow. Oh. Well, if the debate tonight is as entertaining and informative as the social media exchange has been the last couple of weeks between the participants, we're in for a show. I want to, obviously, I want to thank in particular Brookings Mountain West staff on behalf of my colleague Rob Lang, who couldn't be here tonight, but Caitlin Saladino and our students, Lauren, Ashley, Yaneli, and Madison, for whom we would all be starving and standing around not knowing what to do without them. So thank you for helping us get this event here and underway. And of course, to our colleagues in Greenspun College, we're delighted to call this place home and to have this kind of facility available to us. We're live streaming the event for those who couldn't make it. We're also recording the event, again, thanks to our Greenspun College students and staff, including Jennifer Ream, R.T. Thorpe, and Richard Reyes. So we'll have this up on our website in a week or so we can relive all the gory details of what might happen tonight. I don't know if you've noticed there was a rather large red and gray object out in the foyer. We want to thank the athletic department for loaning us the Fremont Cannon. We're not playing for the Fremont Cannon tonight. But we are playing for something a little lighter, a little more mobile, somewhat younger, but I think we'll all agree it has the same amount of prestige, and that's the Great Debate Cup here in front of me. It will be presented to the winning team. We'll have their names engraved on it. It'll be theirs for the next year until we have another event and get to add more names to the trophy. So whoever may win, please enjoy and take care of it. I think we can close our poll now. We've got an interesting distribution. Remember that, because we'll retake it and see what, if anything, changes in the interim. The debate that's going to take place tonight is not what we all may be more familiar with in presidential debates and other political debates, with a moderator or moderators questioning the participants with one or more questions. We have obviously a single topic tonight, and the debaters are going to engage each other in a debate. So both myself and Jacob Thompson, the coach of the UNLV Debate Team, will have a relatively minimal presence in the debate. We will just remind speakers if they get close to or start to edge over the allotted time. But other than that, it's going to be if you can imagine this in today's environment, an adult, information-driven, respectful disagreement on policy. So we look forward to all of that. To the novice debaters who are going to be up on the stage, I just want to say, don't be intimidated by your opponents. Do the best you can. We're still going to respect you tomorrow. But that's enough about my Brookings colleagues. Let's talk about the UNLV debate team, and I'm not sure I can say anything more. I hope you saw that trophy case that I don't think it might not have room for one more trophy out there. The shelves are sagging. I'm going to let my colleague Jacob Thompson speak to that a little bit more. But before I bring our contenders up, I want to invite to come up to the stage Greg Valdez from Congresswoman Dina Titus's office. Greg, you're going to have to shout.
All right. Can everyone hear me? Yes. Great. Okay. My name is Craig Valdez. Thank you so much again for having me. I'm here today on behalf of Congresswoman Dina Titus. For those of you who don't know, she represents the 1st Congressional District, and she also is Professor Emeritus of UNLV. While she couldn't be here tonight, but as a strong supporter of UNLV, Congresswoman Titus would like to extend her welcome to the audience here and to recognize Brookings Mountain West and UNLV Rebuttal Debate for hosting, and the debaters for participating in this forum meant to persuade, educate, and entertain us, including myself. So without further ado, Ember and Jeff, I believe you're the affirmative, kick aff, and Mr. Reeves and Mr. Hudak, break a neg. So thank you so much for having me.
Thank you, sir. Why don't I invite our colleagues up on stage? And as they do, I just want to say a word about my Brookings colleagues, John Hudak and Richard Reeves. Some of you may know here, we bring our colleagues from the Brookings Institution in Washington, D.C. out throughout the academic year. And if you promise not to tell any of our other Brookings colleagues, you have two of our finest here. John and Richard have been instrumental. They visit us often. I always get yelled at if it's been too long since they come. They give lectures in undergraduate and graduate classes. They do research and publish with our faculty and students. They meet with political business community leaders on their policy issues. They've hosted UNLV undergraduate and graduate students back at Brookings. That's a subtle plea to all of you to consider doing that yourself. And I'm thrilled that they agreed and were able to arrange their schedules and join us tonight. So with that, I'm going to ask Jake Thompson to come up and talk a little bit about UNLV Rebel Debate and launch us into tonight's festivities.
Well, thank you very much, Bill. I appreciate the kind introduction and the opportunity to have this debate tonight. I want to tell you just a little bit about the UNLV Debate Team and about our two debaters here. I'll start with by saying that the debate team was established in 2007 when I started here at UNLV, and since that time the program has grown to become consistently ranked among the top 10 debate programs in America year in and year out. Our program is focused on a few key principles: competitive excellence, hard work, teamwork, and community engagement, as you see tonight. And we've grown and improved over time. And one of the things I'm most proud of in terms of our success is that our program has success at every level, from novices and beginners who have no prior debate experience, like maybe our opponents, all the way to folks who we recruited after they had very, very successful high school, 4-year-long high school debate careers. And that brings me to our debaters on the stage tonight. Ember Smith and Jeffrey Horn. They're both hometown heroes. They're both from here in Las Vegas, both Green Valley High School graduates. I recruited both of them to join our team. I remember a recruiting dinner with Ember's parents many years ago. And they are on the top team at UNLV and one of the most competitively successful teams that we've ever had. In the fall coaches poll, they were ranked the #6 individual 2-person debate team in America. They have, that's good. They have advanced to the elimination rounds of every debate tournament that they have attended this year, including the Sweet 16 at Gonzaga and Northwestern, the Elite 8 at Wake Forest, and the Final 4 at the University of Kentucky, and they are crowned tournament champions of the UNLV debate tournament. Jeff is a senior majoring in economics. He's a 4-time qualifier to the National Debate Tournament, which is our national championship. He is an outstanding debater. Ember is a junior, also majoring in economics with a minor in math. She's a member of the UNLV Honors College, and she's a UNLV Presidential Scholar. And I couldn't be more proud of them. I could talk about the debate team forever, but I won't do that. I want to talk to y'all for just a second about the structure and format for tonight's debate. The debate that we'll have tonight is very, very similar to the competitive debates that our students engage in at 14 different tournaments all across the country at various universities across America. There will be so we have 2 sides and 2 debaters per side. There will be 4 constructive speeches at the beginning. Each of those constructive speeches will be 6 minutes long. Each constructive speech, the speaker will be asked questions following that speech in a cross-examination period that's 3 minutes long. So they'll be cross-examined by the opposite team. Following the constructive speeches, there will be 4 rebuttal speeches, and those rebuttal speeches, except for the 1AR, are 4 minutes long, and there will be 1 minute of preparation time where they'll be pulling their notes together and getting their ideas together before they talk in the rebuttal speeches. And as I said before, this is very, very similar to the format that we use in college policy debate. I'd also like to remind you that you can follow along with the format in the program that you probably have in front of you, which lists the name of the debaters, the speeches they'll be giving, as well as the time limits. Additionally, when you walked in this evening, you probably received an index card and a pencil. We invite you to write down any questions that you have, because after the debate, we will be asking some questions of the debaters. You'll notice that there's preparation time allocated in the second half of that debate, and we ask that you be quiet during that prep time so the debaters can prepare, and you might take that opportunity to write down some of your questions. Brookings Mountain West staff are here in the room, and they'll be coming around to collect your questions. If you have them, you can just hold it up, and someone will be there in a minute. Finally, I would like to thank and recognize, finally, I would like to thank our competitors, John and Richard, for your time and the opportunity to debate against you tonight. And I would like to recognize 2 other elected officials who are here with us tonight. My good friend, Regent Sam Lieberman, is here. And representing Senator Catherine Cortez Masto, UNLV debate alumnus, Christian Botto, is here. Without much further ado, I believe that we can start the debate. Ember Smith will present the first affirmative constructive speech.
Good evening, everyone. Before I get started, I just want to say a few thank yous. First, and maybe most importantly, thank you to you all for coming here and being with us on a Thursday evening. I know there's probably nothing better you have to be doing on a Thursday night than listening to an academic debate about healthcare. Second, I'd also like to thank Bill Brown and Caitlin Saladino and the entire Brookings Mountain West staff for putting on this magnificent event and giving us the opportunity to give some guys a lot more degrees than us a run for their money. Finally, I'd like to thank Dr. John Hudak and Dr. Richard Reeves, of course, for spending what little time they have here in Vegas with students like us and supporting deliberative debate. So with that, I will begin. The United States should adopt a universal, comprehensive, single-payer national health insurance system. Under this system, the U.S. government finances all essential healthcare services for every American without any deductibles or co-payments. We contend that there are 2 main advantages to adopting a single-payer national health insurance system: the benefits to our health and to our economy. First, the current for-profit system results in tens of thousands of preventable deaths every year. Approximately 27 million Americans are uninsured. A study by Harvard Medical School estimated that 45,000 people in the United States die every year because they lack affordable health insurance. The study also concluded that Americans without health insurance are 40% more likely to die than those with it. But it's not just the uninsured people who die. Even Americans who do have health insurance forego necessary care because their share of the final bill is just too expensive. A study from Cal Berkeley and Harvard found that people are much more likely to avoid or delay getting necessary health treatment because they had to pay deductibles or co-payments. But they concluded that when there's no out-of-pocket costs, patients are more likely to seek out necessary care and had significantly better health outcomes. Furthermore, Dr. Himmelstein, a professor at Harvard Medical School, found that 1/3 of cancer patients went into debt because of their treatment. This financial catastrophe increases the mortality rate for treatable cancers because it causes people to delay or go without their necessary health care. Medical bills also force families to make devastating and heartbreaking choices. 34% of even insured Americans have difficulty paying medical bills. We're unable to pay for heat, housing, and food. Unless we adopt a single-payer national health insurance system, medical costs will continue to rise, making this problem even worse, which brings us to our second advantage, the economic benefits of a single-payer system. The current for-profit health insurance system is a massive drag on the economy. First, healthcare costs are rising. According to a longtime senior healthcare executive, healthcare expenses currently comprise of 17% of the US economy. But if it continues to grow at that same rate, healthcare will comprise of over 50% of our entire economy by 2060. Everyone here knows that their healthcare premiums are rising, except for maybe the college students in the audience who spent all their money on ramen and beer already. A major source of skyrocketing healthcare costs is the administrative complexities of having multiple different insurance payers in the current for-profit health insurance system. Economist Dean Baker noted that single-payer systems are more efficient because their hospitals and doctors don't have to shuffle endless paperwork back and forth. Every time that anyone goes to the hospital or doctor, they have to figure out what services are covered, at what rate, how much a patient owes, if they met their out-of-pocket maximum, if they paid their deductible, what doctors are included in their provider work, what their reimbursement rates are, and a million other things that I won't bore you with because it's too much for us, and it's more importantly, it's too much on the health provider's time. The enormous cost behind the administrative complexity of having multiple payers is not just theoretical, though. Data proves that single-payer systems all around the world have significantly lower administrative costs and therefore overall health costs. Robert Pollin, professor of economics, wrote that in the UK and other major developed nations with a single-payer system, cost of healthcare takes up approximately 9% of GDP, while the US spends nearly twice as much and receives far worse health outcomes. According to economist Gerald Friedman, a single-payer system would dramatically lower the price of healthcare because it establishes a monopoly, which allows the government to have bargaining power to negotiate lower prices with hospitals and drug prices. Without reducing healthcare prices, many families end up not being able to afford to pay medical bills, which devastates them financially. Rising medical costs are the single largest cause of bankruptcy in the US. A Harvard study estimates that the inability to pay medical bills contributed to a shocking 62% of American bankruptcies. But being able to pay medical bills doesn't just cause bankruptcies. It also results in a more unhealthy population, which is just an additional burden on the US economy. Several studies suggest that increased health outcomes are one of the very few robust predictors of economic growth. The studies are clear. Quality health insurance reduces avoidable illnesses and has an effect of decreasing employment. Poor health services and health also drives people to leave workforce prematurely and file for social welfare programs more often. When Americans are healthier, they work harder, miss less work, and the economy is better for it. To conclude, we know that everyone here is probably thinking, well, that sounds kind of expensive. How are we going to pay for it? Well, I'm glad you asked. We're going to make Mexico pay for it. Just kidding. We can actually pay for the system in a revenue-neutral way by redirecting funding from Medicaid, Medicare, and Obamacare and use a progressive tax to fund whatever remaining costs might be. Single payer also wouldn't cost any of you any additional money. Every single person with employer-provided health insurance is already paying a hidden tax in the form of lower wages and out-of-pocket costs that you pay to your insurance company. That is a tax. Under a single payer system, you may pay higher taxes technically, but you would no longer have to pay the enormous costs of health insurance, and you'd make more money in the form of higher wages. Funding a single-payer system would be easier than you'd expect. Professor John Gaiman estimates that the US already pays $2.1 trillion in taxes to fund healthcare, more than any other nation in the world. That means that our taxes are already paying almost 2/3 of our total healthcare costs in the United States. If that tax money currently spent on healthcare were to be redirected to a single-payer system, with all the money we can save from administrative costs, we would have enough to fund the entire system with no additional cost. In fact, economist Gerald Friedman estimates that over 10 years, single-payer would actually save the US $9.6 trillion because of its simplified design, leading to lower administrative costs and lower medical prices. Friedman estimates that if a tax is necessary, it would be progressive. So even so, 95% of Americans would actually pay less under a single-payer system than they do today. Because it will save tens of thousands of lives and potentially save the US economy, we believe that the United States should adopt a single-payer national health insurance system. Thank you.
Thank you, Amber. My first question starts with some research that's been done back in Washington. So the Congressional Budget Office estimates that a single-payer system in the United States would cost $32 trillion over 10 years. We are currently in a situation where budget deficits are increasing rapidly. We expect a deficit this year in excess of $1 trillion. If we can't pay our bills now, how are we going to pay an additional $32 trillion in bills?
Right. What you fail to account for, though, is all the money that would be redirected from Medicare, Medicaid, and Obamacare, which is already being spent. That would cover 2/3 of the cost that we need for single payer, and the additional money would, according to our experts that we cited, would actually reduce the cost of administrative externalities, like they have to do a lot of paperwork, all the things I listed quickly. That means that it's a lot cheaper to do that, so we actually wouldn't need very much money at all in addition to what we've already put into healthcare in the United States.
So a quick follow-up on that.
Sure.
You said that Medicare and Medicaid and Obamacare money would be redirected. Can you explain how the money that's currently being spent to help people's health care is going to be redirected but then increase others' health care?
So Medicare and Medicaid cover, I think it's around 1/3 of Americans currently in the United States. So obviously all those people would be cared for under single payer, but it would be cheaper to do that because, you know, the United States would have bargaining power to lower prices. It also allows more people to have coverage as well. Do you want to say something?
If I could just jump in there,
sure.
we would no longer need Medicaid and Medicare and Obamacare because there would be a single government program that would be financing everyone's health care.
We understand that the government's going to pay for everybody's health care. Can I ask you a couple of yes/no questions, Ember?
We'll see.
Let's see if you can do these. I think they're yes/no questions. Are you in favour of universal provision of high school education?
I don't know why that's relevant to the speech that I just gave.
It's a yes/no question.
It's really not about my moral judgments as a debate.
We're in favor of a single-payer universal healthcare program.
That's the topic, so come on.
It's a relevant question. If you choose not to answer
I don't really think it is because my ethical beliefs don't affect how I debate.
Are you in favor of universal
I'm in favor of universal single health care.
Are you also in favor of universal high school?
I'll answer questions that are relevant to the speech. I'm in favor of U.S. single health care.
It seems to me that you probably are, but you don't want to admit it because then you know what the next question is, which
I'm
is,
not scared
in that case, I don't think you're scared of me. I hope you'll take the question seriously.
Oh, I don't think that question is relevant to the speech I just gave.
It is.
I'm in favor. No, this debate is not about healthcare or college. Sorry, it is about healthcare. It's not about college or high school universal education. It's about healthcare. We say that a single-payer health insurance system would be good.
Do you agree it's possible to provide a universal service without it being a single-payer national service? Yes or
again, no? We're getting at the same thing here.
It's possible to provide universal coverage without a single-payer system, but our argument is that
Sure, that's all I need. That's all I need. Sorry, could you say it again, Jeffrey? It is possible, right? You can get universal coverage without single payer.
It's a complicated question, but it's hard to answer with a yes or no.
Thank you.
Well, very briefly before I start, I'd like to echo what Ember said as a huge thank you to all of you for coming out on a Thursday night. I do disagree with her. I don't think there's anything better that you could be doing on a Thursday night than this. But no, on behalf of the Brookings Institution, this is very meaningful for us. This is something Richard and I are excited to do, and it's something that our colleagues back in Washington are thrilled to continue our engagement with the university and with two of the university's most stellar students. So, and again, thank you all for coming out tonight. My position, our position, is to disagree with the point that single-payer health care is the right idea for the United States. But I want to start on what we agree on. We agree that the healthcare system in the United States is broken. Costs are too high. The quality of care is too low. That we have uninsured in this country is a serious problem. And beyond the uninsured, the underinsured in this country, as Ember pointed out, also face tremendous difficulties dealing with the day-to-day challenges of their own health care and their family's health care. So we need lower costs. We need better quality, more affordable health care. But what this country does not need is an expensive, unaccountable, dysfunctional, government-run monopsony that is the single-payer system. Universal health care, which we should have, does not mean we need single-payer health care. Canada, Germany, and other countries around the world use multi-payer systems to cover all of their citizens, and they do it in effective ways. We'll talk a bit tonight about the failures of single-payer systems, but unfortunately we are time limited, so we cannot get into all of the failings of a single-payer system. Some of this nation's most progressive think tanks have come up with better proposals than a single-payer system because they recognize the flaws and the challenges both from policy perspectives and from political perspectives. The think tank The Third Way has come up with a system that's essentially Obamacare plus. It's Obamacare with a universal cap on premiums to keep costs under control and to provide automatic coverage for all Americans to create what we truly need, which is universal coverage. The Center for American Progress, another progressive think tank in Washington, has a Medicare Plus option, a Medicare for All option that limits out-of-pocket costs via caps. It allows employer-based coverage to remain for the 70% of individuals who are covered by their employer and like the insurance policy that they currently have. So let's imagine two countries. One is a brand new country with 326 million people in it. The governing institutions are brand new. The bureaucracy is new and agile. That's really hard to imagine. This country has a skilled, diverse, eager workforce that is not yet organized into the powerful economy that it will be. Should this new government implement a single-payer healthcare system just to care for the needs of its citizens, to protect its future, to curb costs, to ensure this enthusiastic workforce remains healthy, engaged, and productive? Perhaps it's more feasible in a new country like that, but it still might not be the right idea. Now imagine another country, also 326 million strong. It has an entrenched governance structure, its economy is powerful and well organized and well established. The entirety of the population depends in part on innovation and in part on stability. It has a healthcare system that serves the vast majority of its citizens, but is far from perfect. 18% of the entire economy, $4 trillion, is devoted to paying for health care. But beneath that surface is not just dollars and cents. It's people. It's the individuals who are providing health care throughout this economy. A massive replacement of an imperfect healthcare system would be a public policy experiment that would be waged on a scale never before seen in human history. Would people be helped by single payer? Certainly, there would be benefits. Will people be harmed? Absolutely, because there are better options to create better, more affordable health care. Ember mentioned administrative processes and paperwork, and if you've ever gone through that with your health insurance company, it is a pain in the ass, to be frank about it. But administrative processes and paperwork are people. It's not an automated system. Those are people with well-paying jobs who are putting food on their families' tables every night because they have a job in our healthcare economy. Simply sweeping those people away because they're nothing but paperwork is hurting American families, and it will incur tremendous economic costs. It will hurt hundreds of thousands of people employed by private healthcare companies, including the 28,000 people who work in medical billing and claims adjustments for insurance companies. Doctors, nurses, hospital employees, some will be sent away. Most of them will have their salaries reduced dramatically after investing in their education at extraordinarily high levels in terms of cash. Such a massive disruption will also hurt medical research, and this is very serious. Medical research, for those of you who work in the hard sciences know, is very expensive in the United States and around the world. The European Union, which enjoys a set of different healthcare systems, which I believe our opponents will point to as some of these great ideas that exist about single-payer systems, depend on the market in the United States to help fund that research. Because the United States is a tremendous healthcare market, and they depend on American patients purchasing healthcare products to continue that expensive research into approving drugs, into approving medical procedures and medical devices. Take a couple of European pharmaceutical companies, Roche and GlaxoSmithKline. And for perspective, the EU has 1.6 times the population of the United States. Roche depends on the United States for the equivalent of 20.5 billion euro, whereas they only get 9 billion euro from the EU. It is expensive to do medical research, and doing this to the United States economy and its healthcare system will threaten healthcare not just in the United States, but globally as well. Thank you. Oh, yeah, that's right. Let's see.
You ready?
I am.
All right. So during your speech, you gave Canada as an example of a universal system with no rationing or tax burden, but factually, Canada is a single-payer system.
So I didn't say they had no rationing or tax burden.
Right. You said that they were a better example of our system. I'm asking, given that it's a single-payer system like the one that we proposed,
that you would point to. I did not point to it.
The only difference in Canada's system and the one we propose is that they don't cover drug costs. Why is that a better example?
So it's not the same example as what you point to because Canada is not a single-payer system.
Literally the only difference is drug costs. So why is that so substantial to make it a distinguished difference?
The point I was making is that you can achieve universal health care without a single-payer system. Canada is not a single-payer system.
So single-payer without drug costs is the difference you're making?
What I'm saying is you can achieve universal coverage without having a single-payer system, which you propose.
Single-payer is good, but only in Canada.
No, it's not only in Canada. Canada is not a single-payer system. No, you don't disagree. It's factually incorrect.
So you mentioned the example of a new country, all right? You just have the audience imagine it. And you're like, this is so crazy, how could the United States do it? But 15 other developed nations have made the transition to single-payer systems. Why does that disprove your example?
How large are those individual countries?
You said the EU was bigger than the US. That's a good example,
The EU does not have a single-payer system for the entire continent.
The EU is not a country, just to point out. The European Union consists of a number of different countries.
Soon to be one fewer, but a number of countries.
If I can just ask a question. So you're saying the size of a country affects how effective the healthcare system is. What is the relevance of the size of the country to how a single-payer system performs?
The talent of this debate team is to put words in people's mouths. I did not say that the effectiveness of a system depends on the size of the country. What I said was that the size of the American economy, creates tremendous costs.
Mean that a single-payer system would fail here but work in the UK.
What I'm saying is that the displacement of 18% of the American economy would be tremendously disruptive, and at a $4 trillion price tag, that is a massive problem for the United States to implement.
How would that be a displacement if we still have healthcare, obviously?
Well, you mentioned all of the costs that are being driven down with administrative processes and paperwork, which are people's jobs.
Because they're trending upwards now, so you don't think that the audience members should have lower premiums? You think they should continue to balloon until 2050?
What I hope for the audience members is that none of you work as paperwork in this economy, because our opponents would have you out of a job.
Right, so I mean, there are plenty of industries that have historically existed, like the typewriter industry or something. Obviously, those people could be retrained. So I think that
ask coal miners about retraining and what their economic outlook is like right now. But if you want more government subsidies for that, on top of this massive increase in government spending, add it to the list and raise your taxes.
When we still maintain a health insurance system that would still have to be staffed?
I missed the first part of your question.
The government would have a single-payer system that would also need staff. That was all. That's good.
Jeffrey, did you think the UK system was working?
I did.
You did.
You really like this.
Now you mean their healthcare system, not all the other parts, right?
Definitely not the whole thing.
Okay. But even so, just wanted to be clear. That's what you're saying.
Tens of thousands of Americans die every single year because of preventable illnesses. Our opponents have failed to address the study that we introduced in our first speech from the Harvard Medical School that concluded that when there is a deductible or co-payment attached to an insurance policy, Americans do not forego necessary treatment that oftentimes results in horrible, untreatable chronic illnesses that develop into disabilities, or in a lot of cases,
preventable mortalities or deaths. The counter systems they have proposed, such as the ones that exist in Germany, in Japan, those all have deductibles and co-payments that you must pay in that system. They have presented no evidence that disagrees with our claim that when those deductibles and co-payments exist, individuals forego necessary care and oftentimes die because of it. And it's not only that they die, even when they have a chronic illness and manage to not die, they still have to quit the workforce, file for disability, which shows up on all of your taxes. They drop out of the labor market, or they are simply less productive at work, which was all part of the Harvard medical study that we cited, which means that even if there are people who might have to be retrained to go into another industry, the amount of jobs that would be created, saved, the amount of people that would be more productive at work who would not have to file for disability because their overall health is better would far exceed any of the administrative clerks that would have to go into a different industry. They brought up that Canada is a successful example of a non-single-payer system. Canada is a single-payer system. Their government literally funds every health service except for drugs. They have agreed with single-payer national health insurance being a good idea. The other two examples that they gave were of Germany and of Japan. Germany and Japan both have over 20 private and public insurers in a very complex administrative system. They failed to address the studies that we cited in our first speech that says that as long as there are administrative complexities, as long as doctors have to figure out what is covered on an insurance program, how much people will pay for it, etc., they have to spend up to half of their time figuring out that stuff, which is extremely inefficient and expensive. It will lead to a trend where healthcare consumes half of our economy by 2060, which is very obviously unsustainable. They are right that those administrative complexities are people's jobs, but anytime there is an innovative solution to a problem, like when the Pony Express didn't exist and we invented trains, we trained the people who ran the Pony Express to operate trains. It is very simple. The people who have skills in the healthcare industry, like the clerks who work for insurance companies, would be retrained by the government to run the government program that needs to be run in a more efficient fashion. Healthcare providers could very easily hire them because they have skills that are relevant to the healthcare industry. And as we mentioned in our first speech, just because there is a single-payer system doesn't mean that the government is the only provider of healthcare. It means they provide all essential services. There would still be supplemental policies for dental, vision, cosmetic care, and other non-essential services. So there would still be insurance companies that exist. They mentioned the German system, and the problem with the German system is the administrative complexities and the costs associated with it still cause people to skip care. A study from a German medical journal cited that 1/3 of Germans self-reported that because of the deductibles, the co-payments, and the massive confusion and complexity behind their multi-payer system, 1/3 of them skipped unnecessary, essential treatment because they just couldn't afford it. The American Medical Association also released a study that says that those complexities in the German and the Japanese system that they are citing are the leading cause that doctors are not entering the medical field, are dropping out of it, or simply cannot spend enough time with patients. People are frustrated with the bureaucratic hassle of having to spend half your time dealing with an insurance provider. Like seriously, no one goes to medical school and is super amped about the exciting, exhilarating opportunity to spend half your day dealing with insurance companies. The single-payer system that we're proposing would free up doctors' time so they'd be able to spend more time with patients. Their hospitals would be more profitable while at the same time more efficient in delivering a better quality product for Americans. They mentioned all of the stuff about people having to just be out of work. It's simply not true. The system would be phased in over time. There are 15 countries globally that have switched to single-payer systems that had a private system. All of those countries figured it out. They were able to retrain individuals who worked in those industries, and they were able to find other jobs because it's not like the system just pops up overnight. They were able to think about it and establish retraining programs. Even if they prove that there would be some short-term disruptions in the labor market, don't forget that the people who are dying from chronic illnesses and preventable cancers because they can't afford their treatment, those people are people too. It's not just the administrative clerks that are people. The people who have to quit their jobs and file for disability because their chronic illness that they delayed treatment for because they couldn't afford their insurance, those are people too. The economic benefits of a single-payer national health insurance system far exceed any short-term disruption in the labor market. Gerald Friedman, the statistic we cited in the 1AC, estimated the cost savings at $10 trillion in 10 years as a result of making our healthcare system much more efficient. Lastly, they mentioned that research would be harmed because the countries in the EU that have single payer depend on the US. First of all, this is simply not true. Countries in the EU are very innovative. It is a fact that pharmaceutical companies in the US spend 15 times the amount that they spend on research and development on advertising, making Me Too drugs. The single payer system would mean that they wouldn't have to spend any money on advertising because they wouldn't have to get hospitals or patients to buy their drugs. They would just be, the government would be buying the drugs from them. They could very easily redirect that advertising funding that they spend most of their money on research and development. They would also make more money because there'd be more patients that have health insurance. Like, just think about it logically. It does not make any sense that if no one can afford health insurance, they can sell a lot of drugs. We make it so they can buy all of the drugs that they want when they need them, so pharmaceutical companies would make more money.
Good. Yeah. So, I just want to have some clarification about this. So, Jeffrey, this is generally just a clarification question, because part of the debate here seems to be how we're defining which countries are single payer and which ones aren't. You say Canada is a single payer.
Correct.
You say
like Germany can Google it.
Germany,
like
yeah, you can.
Yeah.
Germany is not.
They are not.
Japan?
Not.
Okay, and you think we mentioned Japan?
I thought that you referred to Germany's multi-payer system, which is very similar to Japan's.
We had cited Japan in our earlier proposals.
If you didn't, that was my mistake. Germany is a multi-payer system that uses all-payer rate setting, which means the government just sets the prices, but there's still private insurance companies.
There are private insurance companies, yeah. And if I'm a German citizen,
Mm-hmm.
I can choose between different private insurance companies. I can choose different policies.
Yeah, they
are highly regulated. They have government backing, etc.
Absolutely.
So it's a very highly regulated market.
Correct. And,
and it's not good enough as far as you're concerned.
That regulation of the private and the public insurance companies is the administrative complexity, the confusion, and the inefficiency that we are talking about. It also requires people to pay deductibles and co-payments because the health insurance is not financed in its entirety by the government, which our studies that we have cited from the Harvard Medical School say that when those costs are attached to private insurance policies, that people forego necessary care, which is bad for people's health, it's bad for the economy, and it just makes for a bad system.
So 70% of Americans with employer-provided health care like the health care that they have in public polling. What would you tell them, with those people who are happy with it?
Their plan would be necessarily better under a single-payer system because they wouldn't have to pay a deductible or a co-payment, and they'd keep the same doctor.
So they just have to take the government's word on that one?
Well, maybe they don't believe it at first, but the studies that we have cited indicate that the savings, which are $10 trillion over a 10-year period, would be realized. And I think people would see that the inefficiencies that would be resolved by a single-payer system would benefit.
How many Harvard studies do you think someone on disability has time to read in a given day to convince themselves your idea is good?
That kind of misses the point, because they might not be in favor of a single-payer system initially, but once they see that their wallet is performing better because of it, I think they would like it.
But you're going to force them to give up the policy that they currently have and that they're very happy with.
I'm confused what you mean by force them to give up. The government pays for all their health care, so what are they giving up?
Are they allowed to
giving
have
up their health insurance plan?
But they have free health care for the government, so what are they giving up?
The government will force them. So the government is by virtue of
Yes.
So to be clear, because the government's offering something for free, which you say is better, it's okay to stop me from getting that thing through another means
I guess you're right, Dr. Reeves, that they would have to give up paying money to their health insurance company, but I think that they would like that in the long
term. Again, I know you don't like the education analogy, but if you provide free public education, are you therefore, by the same logic, allowed to prevent people using private education?
The debate's about healthcare. We really don't like that.
By the same logic? I bet you don't. Yes. I can certainly see why you don't like the arguments when they don't go your way, but I don't think it's a very good idea to just dismiss them. It's more persuasive, in my view, to engage with those arguments and to show why they're wrong, rather than just say, I'm not talking about that. I don't think that's very persuasive. So it seems to me that our opponents so far have done an exceptionally good job of describing the problems with the current system. We've had litanies of people dying and diseases all over the place. And then, so we need single-payer national health service. Right? Just like that. The first thing we have to make clear is that you can get universal health coverage without single payer. You do not need the government to take over the entire health system of the country to achieve the goals that we share with our opponents. They are trying to elide the difference. They want to persuade you. You've got to go all the way to single payer. Even Germany's not left-wing enough for them. Their system is still too private sector, right? We're talking about the United States of America here. And you know there's that old joke when you ask a local direction somewhere. You go up to a local and you say, I need to get to there. And they say, well, I wouldn't start from here. Well, the trouble is we have to start from here. We have to start from where we are. Most of the countries that moved to single-payer systems did so long before their health markets had developed. It would be an extraordinary transition for us to make at this stage. So yeah, lots of problems. There are better solutions that do not require massive government takeover of the healthcare system. There are three big problems, in addition to the ones of disruption and costs of jobs that John has already mentioned with single payer. Cost, rationing, and coercion. Cost we've already covered pretty well. Quote as many academics as you like. The Congressional Budget Office, independent, has costed it $32 trillion over 10 years. And yes, you're right, we won't have to pay as much in other forms of private insurance. In fact, you won't let me, apparently, in this new brave new world. So even if I'm actually not worse off as a result of the massive taxes, you're going to have to roughly double the size of federal government to achieve it. Okay, even if on net I'm not worse off, it's still the government doing it for me, rather than me doing it for myself. And it's not as if the doctors are making out so well in these expensive systems. In Sweden, you probably love Sweden, specialist doctors make $77,000 a year compared to $230,000 in the US. So anybody who's thinking about going to medical school and thinking about going to Sweden, don't. Stay here. Secondly, rationing. By definition, single-payer systems ration healthcare. In fact, that's one of the arguments that they make in favor of them. They do it in one of two ways or both. Number one, through a government panel telling you what healthcare you can and cannot receive. The closest we got probably to universal single-payer healthcare was when Hillary Clinton was working with her husband, and in section 1141A1 of the 1993 Health Security Act that didn't pass, it would have created a National Health Board, a 7-member panel appointed by government that would decide, quote, what constitutes an item or service that is not medically necessary or appropriate. In the United Kingdom, which they appear to love for its health service, government-appointed panels deny people health care that their doctor has prescribed for them. I know what I'm talking about. And yes, this Harvard study, okay, we'll address the Harvard medical study. And my God, one Harvard study seems to carry a lot of the weight of your argument. Yes, it's true that some people, when they're faced with co-pays or difficulty paying for things, will not take that care. And it has deleterious health consequences. It's true. But I tell you what also happens in a single-payer system. You wait. The second way you ration is by queuing. In the UK right now, the average person waiting for a knee replacement or a hip replacement is waiting 6 months. Now, maybe you don't think 6 months sounds very long, but I tell you what, you will when you need a new knee or when you need a new hip. So we wait and we wait and we wait until we make it to the front of the queue. And it seems to me that healthcare is too important to be something that we have to wait in line for our turn to receive, which is inevitable under single-payer health systems. And these waiting times are not just inconvenient. They, to quote another study, this is the Fraser Institute, just because we like to name this, where the study's from. Wait times can and do have serious consequences such as increased pain, suffering and mental anguish. They can result in poorer medical outcomes, transforming potentially reversible illnesses or injuries into chronic irreversible conditions, even permanent disabilities. The patients may also be foregoing their wages if they're unable to work while they wait. So if you want a system where you've either got a government-appointed panel telling you you can't have those drugs that your doctor said you need, welcome to single-payer National Health Service. If you want a system where you have to wait in line for months and months and months for your healthcare, welcome to single-payer National Health Service. Thirdly, it's coercive. And I'm glad that Jeffrey was honest enough to answer that question. All Americans will be covered for these services. Single-payer National Health Service means the abolition of employer-provided health insurance in the US, our main way we provide health insurance here. more than half of Americans, 180 million people, currently get their health care through employer-provided health insurance. And as John has pointed out, 70% of them are very happy with that. In the end, law is a monopoly of violence. In the end, the way you enforce a law is because you're the government and you have a monopoly of violence. You can force people. And therefore, it was technically correct to say that under this scheme, approximately 125 million Americans who have employer-provided health care and are very happy with it will be forced at the point of a gun, in the end, because that's what law is about in the end, to ditch a benefit they willingly purchased and are very happy with. This seems to me to be a pretty draconian way to solve the real problems we have in our healthcare system. There is a lot that is wrong with US healthcare. Don't get us wrong. This is a very, very tough nut to crack. But we do not need a sledgehammer to crack it. Oh, no water.
So, out of curiosity, if you can't afford your health insurance, or say you're uninsured, how long would you have to wait to get a knee replacement if you can't afford it?
Sorry, is that a question?
Yeah, I mean, you said that the single-payer system we propose would cause a lot of rationing and long wait times. In our current situation in the United States, and in a lot of those multiple payer systems that you propose, people can't afford their premiums or deductibles, or they simply are uninsured. How long do those people have to wait to get a major $100,000 surgery?
Okay, so you've just put two groups of people together. You've put people who are insured and who can't afford the copay, and you've lumped them together with people who don't have any insurance. Could you please clarify the question? I'm just
saying that both those groups of people, and oftentimes, cannot afford to get the healthcare treatment they need, and thus, by definition, have to wait forever. I'm asking, how do those people get the healthcare treatment that they need?
Well, we don't. First of all, we have to know a lot more about why someone's not insured. Some of the people who are not insured, in fact, the majority of people who are not insured have made a decision, very often a very difficult decision, not to take out healthcare insurance for whatever reason. Some of those, if they're then faced with a cost like this, are forced to pay that themselves, capacity to borrow from friends and family to do it, in order to get the kind of healthcare that they need. Of course, in the end, everyone is legally entitled to emergency healthcare in the US. We actually have changed the law so we don't leave people behind. So just to be clear, what you're talking about here is not emergency
but
care.
You can't get treatment for cancer in an emergency room. That's a little bit different than what we're talking about. I just want to ask about, you said there's government panels that decide healthcare in countries like the UK. The UK has a system that both establishes government control over hospitals and finances healthcare. The reason they have those panels is because they establish government control over and actually run the hospitals. Our proposal does not do that. So why would a single-payer system that only finances care at private hospitals cause that type of government intervention?
So I think it's fair to say that you don't necessarily have to run the sorts of panels that you run in the UK in your system. But you have said that one of the advantages of single payer is that it brings costs down.
Right.
And the primary way that it does that, it is partly true that it does that because of its ability to negotiate as a single payer, but it also does that through the rationing of healthcare, and it's forced into
40
rationing.
seconds, one more. I agree with that, but we've also cited studies that say that even though doctors would be paid less per service because they'd see so many more patients because everyone has free health insurance, they'd make more money under the system. And our evidence actually cites in Canada that doctors make more than they do in the US. So how is that true in the context of our single-payer system?
Sorry, what's the question?
Well, you were right, they'd be paid less per service, but they would make more money overall because they'd see more patients because everyone has health insurance.
Everyone in the United States clearly wants to go to a doctor that has longer wait times because they have so many more patients to see.
This proves that there wouldn't be the longer wait times.
I think John answered your question.
Okay,
we don't disagree there are problems. We just don't necessarily need a totalitarian government takeover of the healthcare system.
So we've talked a lot about the imaginary. What would a single-payer system look like in the United States? But we don't only have to think imaginary. We have a real single-payer system in the United States, and it's the VA system. So let's take a look at how well the VA system works. There are just over 18 million veterans in the United States. About half of them, 9 million people, are insured, or rather they seek health care as enrollees in the VA. According to a 2017 Westat survey, 63% of VA enrollees used non-VA healthcare services. 2/3 of those people, those veterans, did so because it was easier to access those services than it was at the VA in America's single-payer system. Fully 80% of VA enrollees have another form of health insurance just to meet their health care needs. And while veterans are supportive of this system generally, it has serious challenges. Fewer than 2/3 of VA enrollees, for example, approved of their ability to get referrals to specialists to get those hip and knee replacements. Since 2014, the Office of the Inspector General for the Veterans Affairs Department has shown hundreds of thousands of veterans waiting for consultations and procedures. Now, some will falsely make the claim that those veterans died while on those lists. I will not make that claim because I don't think that's accurate. However, we don't need veterans to die in order to say that our heroes deserve better. This single-payer system is disastrous in terms of accountability. Each year, the General Accountability Office for the federal government puts out its high-risk list of problematic agencies in the federal government. And just yesterday, the newest high-risk list came out. And guess who made the list? The VA. Why? Because it's at high risk for leadership instability, high-level vacancies, and a lack of accountability. The report says it's especially vulnerable to fraud, waste, abuse, mismanagement, and faces its most fundamental functions having problems in the delivery of healthcare services and contracting. The VA has a $200 billion annual budget to provide a dysfunctional, unaccountable, incomplete, single-payer healthcare system to just 2.7% of the United States population. Americans don't trust their government now. Why should we expect them to trust their government to take over their health care if they can't even do it for America's veterans? And one last thing, that GAO report, it's right here. I left the other 292 pages upstairs in my office.
No, there's no.
Oh, I thought there was. Oh, I was ready. God, that's the easy part.
I'll cross it down to you. What a bunch of rubbish.
I know.
It's just feeling.
We'll have 1 minute of preparation time before each of these last rebuttal speeches here, and just plenty of time if you have questions that you have thought of during the debate to write them down in your note cards, and folks will come around and collect them from you.
45,000 uninsured Americans die every year because they lack affordable health insurance. It's clear that they agree that this is a big problem, which seems kind of strange to me because this is a debate, but they continuously agree that universal health coverage is a good thing. Also, it seems a little odd that they continue to do this throughout every speech. They cite this CBO study. While they may have accurately projected the cost of single payer, what our opponents have not responded to is our different mechanisms of how we could overcome this cost. The United States already spends trillions and trillions of dollars on Medicare, Medicaid, and Obamacare that could be redirected to pay for the single-payer system. This would cover 2/3 of that cost. The other 1/3 of the cost for single-payer system would come from the administrative complexities that we just abolish, which reduces the cost substantially. We have a slew of experts to back this up. No, not just our Harvard study. We have some other ones too. Their next biggest argument is about Sweden and Canada. Sweden, first of all, doesn't have a single-payer system, and Canada doesn't have the same type of system that the United States would after our single-payer program. They say that rationing becomes a really big problem. This is all just fear-mongering. The study by the University of Toronto demonstrated that Canada and the UK have the same number of same-day appointments as each other, but the United States would have more because we have a much larger supply of doctors, and that we'd be able to get them equally as quickly. The other single-payer systems in the world also prove this. There are also arguments about the government panels just like coming out to get you, trying to deny you care, do not apply to our arguments at all. Their argument is is about the health care that is provided by the government. Our argument is just that the insurance costs are covered by the government. We still maintain private health insurers. That's a very key distinction that they seem to have ignored. They also have demonstrated that there could be potentially longer wait times. And Dr. Rees mentions that he should know, but don't just trust his accent about it. We have evidence that supports it. The Toronto study also demonstrates that there were no increase in wait times. The U.S. has a larger supply of doctors, and all that time that doctors have to spend on all the paperwork and administrative complexities, they can now spend with patients, which means that they have more time to see all you whenever you have a problem, like medically. And also, it seems like Dr. Rees' background in philosophy hasn't done him well, because in Econ 101, we learned that when demand increases, so does the supply and response. So next, their argument is about coercion. It seems really strange to me that they're up here like on a soapbox talking about how scary it is to have free health care. Our argument isn't that the government's going to decide if you live or die. It's that they decide to give you free health care. If you don't want to use it, I guess you don't have to. That's your prerogative. You can also get supplementary health insurance from other insurance providers, another point that they haven't addressed. So all those people that they say become unemployed no longer have to, because we still need care for things like cosmetics, dental, eye care, etc. So we have a lot of different evidence and examples of like 15 different countries that have made this transition successfully, and it demonstrates pretty clearly that the United States can too. Dr. Hudak addresses the VA system and spent his entire time talking about the VA system, but I think he kind of forgot that we're not advocating a VA system for everyone, we're advocating a single payer system. The key distinction is that in the VA system, similar to the example they gave about the UK, healthcare is provided by government hospitals, and it is grossly underfunded. This does not apply to our arguments at all. There's a very key distinction. None of them apply. So any scary statistics he cites is probably true of the VA. I definitely believe that, but it's just not applicable to our arguments. A better example of a single payer system in the United States demonstrating that our plan would be very effective is Medicare. Medicare covers a lot of the elderly population in the United States and is able to very successfully implement this program at 1/6 of the cost of private healthcare insurance, and they have virtually no wait times. This is a fantastic example of how it would realistically be. So if they have a qualm with that, I guess we'd love to hear it, because none of the VA system arguments apply. All of their unemployment arguments also ignore the fact that right now the U.S. economy, 17% of it is comprised of healthcare costs, but that's projected to increase to 50% by 2060. That means half of your income is going to healthcare. That is just not a sustainable model for the United States economy, which means that we can retrain people and introduce them into the healthcare market to prevent the unemployment, but it can reduce the cost for everyday people who are literally dying because they have to forego or just ignore their treatment because they have to consider, I was just diagnosed with cancer, how is my family going to pay for it? That is a problem that we should be addressing in the United States, and we should be doing it through a single-payer national health care system.
What am I supposed to do?
If you would like a minute of prep time, you could have it.
Oh, I see. No, I think I'm okay. Yeah, let's make everything free. Yeah, I'm in favor of free everything. The issue here is what is the best way to solve the problems that we face. We've been accused of scaremongering. Clearly, we're trying to make our argument. I didn't want to play this card, but I think I'm the only person on this panel that's actually grown up under, lived with a single-payer health system. And I can tell you that there are government-appointed panels, and they will deny you care, and it does happen. So don't trust the accent. Trust my experience. And we can agree that there are pros and cons to all the different approaches that we're taking here. It's a very, very difficult policy area to get right. I think one of the difficulties here has been to keep a really firm grasp on what our opponents are actually proposing, and it's difficult in the time they have available to actually set out a whole healthcare plan. I sympathize with them. But I just noticed right now that Ember said 2/3 of it could be paid for by Medicaid and Medicare and Medicaid transfers, and the other third could come from administrative savings. But in her opening statement, she said it would come from progressive taxation. So which do you think it is? I don't know, and nor do you. It seems that Ember's not sure about it herself either, because she's given us two different ways she's going to pay this $32 trillion. And I put it to you, that might be reason enough just to pause before we move forward. This is a scorched earth strategy to try and solve a real problem. It's somewhat akin to the decision by the Soviet Union to collectivize agriculture. It was a big deal. Didn't succeed very well, as it turned out. And so it's not that we don't think that people have their heart in the right place. It's not that there aren't arguments for and against single payer. It is that from where we are right now, given how the US healthcare system currently is, the idea that we move wholly to a government-funded system is utopian, but unfortunately not in the best sense of that term. A single-payer healthcare system is not the way to get universal coverage. Our opponents have tried desperately to make the math work, to cut costs here, get it from there, save jobs here, add jobs there, ration, etc. Again, I sympathize with their task, but it's quite clear even from the changes in their funding strategies that we've seen, there is more than a bit of magical math going on here. And you're right, Ember, I'm a philosopher by background, but I still know when someone's trying to get one over on me with their numbers. A single-payer national health service would be unprecedented in US history in terms of the reach of economic and social policy, effectively a hostile government takeover of an entire industry. It is unnecessary to achieve the goal of universal coverage. As John's just mentioned, there are a number of ways we can get to universal coverage with a strongly regulated market, multiple payers, and a public option. It is un-American, and I will say this as a new American, it is un-American in its removal of individual choice and discretion and the handing over of massive powers to the federal government. Maybe to many of you, in fact, to some of you I see from the early votes, single-payer national health service, or free healthcare, as we're now going to call it, sounds nice. Certainly it's well-intentioned. But even if you still think that it's a nice idea, I hope, having heard this debate from both John and myself and from our opponents, you will have become convinced that even if a nice idea, it is very definitely not a good idea, and that you will cast your votes accordingly.
Before I deliver our final speech, I just want to take the opportunity to once again just sincerely thank Dr. Reeves and Dr. Hudak for taking time out of their busy schedule to come participate in this debate from us.
We know what you're doing.
And I also really want to thank Brookings Mountain West for making this fantastic opportunity possible, and of course all of you for coming. So with that, single-payer national health insurance is not just free health care. It's not just some utopian idea. We have presented statistics from Nobel laureate economists such as Gerald Friedman, who have estimated that the current trajectory that we are on is the administrative complexities behind the current system will consume half of our economy by the year 2060. They have cited numbers from the CBO about how a single-payer system would cost $32 trillion over 10 years. But the argument that we have made in our previous two speeches is that that saves $10 trillion from the current trajectory that we are on because it simplifies the system. That same study estimated that the current trajectory would put us on a path to $49 trillion by 2060, which would be half of our GDP. A single-payer system creates a simplified design where doctors no longer have to spend half of their time inefficiently asking insurers what is covered, what rates, how much does the patient owe, what doctors do they have to go to, but instead can spend more time with the patients and more time actually performing their jobs, which is where the source of all the savings comes from. It isn't some magical funding system that they try to suggest that it is, and they simply have not addressed the source of the savings that we have identified that it is coming from, such as the administrative complexities. We have also forwarded the argument that because our Harvard Medical Study says that when there are deductibles and co-payments, such as under the multi-payer systems they have proposed from Germany, individuals, about a third of them, forego essential medical care, which kills 45,000 people a year from preventable cancers and other forms of horrific diseases. But it's also an economic problem that helps us pay for the single-payer system and puts our economy in a better spot overall, even if there has to be a modest tax increase. Because the people that are unhealthy, that forego that type of treatment, those people end up on disability. They end up costing you more in taxes. They end up quitting their jobs because they no longer can perform their job, and they end up missing lots of sick days and lowering worker productivity. They accused us of changing our funding scheme throughout the debate. We've not done
done this. We simply said in the first speech that the administrative savings from the $10 trillion in administrative savings from a simplified design would allow us to fund a single-payer system with the $2.1 trillion we already pay in taxes to the government for healthcare. What we said is that even if there was a necessary modest tax increase, such a tax increase would be progressive, which means that the top 1% would fit more of the bill than those who are in poverty. They make this argument about rationing. They did not address the study that we presented in our last speech, which is that this is fear-mongering. It is not true that there are government panels in Canada, which is the most analogous system to what we are proposing, that ration healthcare. In Canada and the UK, they see doctors faster than we do, which was the evidence that we presented from the University of Toronto study. Additionally, ask yourself, would the person who is waiting 6 months from a knee replacement even be able to get a knee replacement in the United States? They wouldn't, because the form of rationing that is endemic to our current system is rationing by not having the money to pay for that knee surgery or replacement in the first place. Even if they prove, which we strongly disagree with, that those wait lines would exist, those people in the wait lines are eventually getting a knee replacement that they otherwise wouldn't have had in the US. Another reason that type of rationing wouldn't exist was because the American Medical Association study that we've been presenting throughout the debate says that there would be more doctors that had more time and there were more doctors that work in hospitals to deal with the increased demand under the system, because they no longer would have to deal with half their time being eaten away by having to deal with insurance companies, which is the number one reason that doctors are quitting the profession, retiring early, or not going to medical school, and they spend half of their time doing that. The last argument that they made was that it was coercive totalitarianism. The government is financing healthcare because it's a more simplified design. They did not respond to our example that Medicare is a single-payer system in the US for the elderly that provides quality healthcare with no wait times at a shocking 1/6 amount of the time. Seriously, people, this is a no-brainer. It saves lives, is more efficient and saves money, and every other major developed nation has a single-payer system. Even the Brits have figured this out. Obviously, we can. Thank you so much. Thank you so much. It was a great debate.
Can we keep going?
Could we give our debaters another round of applause, please, for a great job? While I make a few remarks, I'm going to ask you to re-vote, and if you've changed, obviously, vote in the category your opinion has changed to. While you're doing that, I want to, no event like this, nothing that we do at Brookings Mountain West could be done without the generosity of our donors. So I want to acknowledge some of them. They include MGM Resorts, Barrick Gold Corporation, Wolfgang Puck Fine Dining, and a number of individuals, including Brian Greenspun and Tom Kaplan, who was here in the audience. So thanks to all of them for allowing us to have convenings like this. I see our votes compiling as we speak. And the undecideds seem to have decided. I'm going to let that continue just a second more. We don't want to leave anybody out if they're still debating. What we're going to do is take a look at this final number. We'll declare a winner, and then Jake and I will get to a little Q&A with our debaters, take them out of their debate role, and ask them some questions about the actual process and that. I think we might feel comfortable. I don't see any hands. Anybody still voting? Okay, we'll wait another minute or two, second or two. How about now? Any hands out there? Looks like we might be done. With all the power vested in me by the position of moderator, I hereby declare the voting closed. If you remember where we started, it was yes 35%, undecided 21%, no 45%. Mr. Thompson. To whom does the trophy go?
I'm in the odd position presenting a trophy to my own team. Congratulations.
Just right here. Wait for them.
Congratulations.
Thank you.
Well, I also want to take a moment, though, and recognize the contributions of our colleagues who didn't quite change as many minds as they might have. In recognition of their work, we actually have individual trophies for them. So.
Well, these aren't big enough for a martini. The least he could have done was martini glasses. We'll take it. You know, no one else at Brookings has these, so we made out.
We're planning to drink out of the cup.
Fortunately,
Yeah, it is actually shot glass sized. It's actually
fortunately,
a tumbler.
nothing is so
see.
good after a policy debate as something about the size of a shot glass.
It's true.
So, let me then congratulate both our debaters. We're going to start off with a couple questions of our own and then turn to some of yours. We have a few minutes, but we want to be respectful of your time. So my first question to both pro and con folks, how did your opponents do? Did they surprise you with something? Did they catch you unaware? How did they do?
These are pretty big vocabulary.
No, I thought they did really well. All of the main arguments that they presented were actually the most common and well-researched arguments that we encountered when we actually debated this topic for the full season against the most competitively successful college debaters, and they really did an excellent job of illustrating the best flaws, I think, in the single-payer system. So,
Did I forget to tell you that?
Yes. You did, Bill. Yeah,
That's my bad.
I was astounded when you asked us what topic we wanted to debate and then let us choose. So.
Well, that's the home court advantage. It won't always be that way. To John and Richard.
I thought they performed as well as you would expect of a team that had been doing this for an entire year. Personally, no. In all honesty, I did not know what to expect as someone who didn't ever do debate before, and that's not, again, to undersell expectations, but I literally didn't know what this was going to be like. But the arguments were well reasoned. They were, I think, the math remains very, very fuzzy, but I mean, despite that, they had the harder time, except for the year of prep. But I mean, they had to defend a system, and we had the opportunity to offer any set of alternatives. That is naturally a more difficult task for them to have to do. And so, hats off for having the harder side. I would argue to take and to do well accordingly.
Yeah. And as not a follow-up, but another question for you, John and Richard. Would this be a good time to discuss the fact that Ember and Jeff are interested in doing an internship at Brookings?
Should we wait for the sting to subside just a little while before we?
Just give it a couple of martinis.
A couple days or.
Jake?
So I want to ask both teams if there's an additional argument that you wish that you'd been able to make. What was something that you would add, now in retrospect, to the arguments that you put forward in the debate initially?
I probably would have taken a harder approach on the actual financing. I mean, we did a little bit of that, but I don't think we did that as well. That financing just doesn't add up, honestly, and so they did a very good job putting it forward, but there are a lot of ways to think differently about the holes that are in that math, and plenty of studies to support challenges to that math as well. That I probably would have done more.
Actually, the only thing that it was a rhetorical device that we were planning to use that we didn't, and maybe it wouldn't have worked anyway, but depending on how you define single payer, and obviously we had a bit of an argument about that, on a lot of people's definition of single payer, the biggest country by population that has a single payer national health service is Iran. And so in the cross, what one thought we'd do is to say to Jeffrey, do you know which one is the biggest one? And if he'd said no, we'd say, well, it's Iran. And then we were planning to say, are there any other elements of Iranian society you'd like us to emulate?
It was going to be more than a rhetorical flourish, too.
Well, hopefully, yeah.
Well, no, Caitlin wouldn't let us have our prop. Yeah, so there was
that's
that.
a whole different story, don't go there.
I think we would have liked to add a few more British jokes.
I think you had enough of those. I think you had enough of those.
I know, but I think we also could have done maybe a little bit better of clearing up the financing system. You know, I think both sides maybe could have done a better job with that, so we could like defend our position a little better too. Because I do think, like in my speech, I didn't mention the progressive tax for the leftover money, which I think could have created some confusion. So I think that like clearing that up would have been a little bit more ideal than what we ended up doing.
One more, Jake?
Sure. We have a question from the audience here then.
Please.
Okay. Do you believe that an incremental transition to single payer would be more effective than an immediate transition to single payer?
Oh, God.
So,
well, I mean, it's not. I mean, there's no question to it. It would be, I think, from a policy perspective, absolutely impossible to do. Even the Affordable Care Act, which is minuscule by comparison, had a 5-year phase-in effectively. And so imagine Obamacare times 50. You would have to do it that way. And one of the points is on doctor training, right? So if doctors' wages are going to go down, which they're much lower than in the United States, much lower than in the United States, you couldn't say to someone, hey, you have $500,000 in student loan debt. By the way, your salary just got cut by 70, well, not 70, 30 or 40%. So that is one point that I think signals broader disruptions that this would cause if it were an immediate phase-in.
I think that you don't know what will happen in the long run, right? I think we tried to argue that just going straight to single payer would be massively disruptive, and we obviously didn't win that argument. But I think actually you can imagine a series of reforms that a long way down the line could possibly get the US to that place. I've just read this book by Martin Luther King where he said the following: to lightly dismiss a success because it does not usher in a complete order of justice fails to comprehend the process of achieving full victory. It dissolves the confidence born of a partial victory by which new efforts are powered. And so I do think that actually, we shouldn't rain on so-called incremental policy changes because A, they're much more likely to happen and be sustained, and B, they might be a step towards a more radical one. It's just that you can't get from A to B very quickly. It'll be a long journey for the US given where it starts.
And I think that's a good lesson for our legislators, present company excluded, about the importance of incrementalism over just big, flashy ideas going all at once.
Yeah, I mean, it has, absolutely, like I said, it has to be incremental. And most of the plans that are actually offered in the healthcare literature that we researched, at least, do not say we should implement a single-payer system from where we are now. Most of them actually offer, an idea where the government can incrementally offer a public option to individuals, where the government would offer a plan that would compete with private insurance, and then over time they can then build into potentially something closer to a single-payer system. But absolutely, I think it's obviously incremental is the only way.
There's another question here from the audience, and I'll just kind of summarize 2 or 3 of them by putting them together. What do you really think? They're curious. They want to know how good you were at playing your role, I guess, and what your kind of personal beliefs about the resolution might be, briefly.
I'm happy to go first on 2 points, actually. One on, and I'll make a point about debate as well. the National Health Service in the UK is a fantastic service. I hugely miss it. It's just a brilliant system. It has all the problems, some of the problems that I mentioned, and and there are panels and all that. But you know what? That's what it takes. If you're going to be serious about the allocation of scarce resources, you have to find a way to do it. And the National Health Service does it brilliantly. But it was born in out of World War II, in a particular environment. So my comments about the NHS should be taken with a real grain of salt. So but I do think I agree with most of what we argued, actually, given where the US currently comes from. The other point I just wanted to make is about debate, the purpose of debate. Because I think what's great about a debate, especially when it's formalised like this, is to allow us to argue very strongly, as we did, against ideas and really bring kind of blade on blade around those ideas, knowing that it's in the service of the debate and us all getting a bit smarter. I think too often we actually clamp down on free speech because people are so identified with their ideas that for me to attack your idea is somehow to be attacking you. And actually that's profoundly dangerous.
Yeah.
If you get to a society where me attacking what you've said or your idea is an attack on you as a person, because then it clamps down free speech. So debate is a really formalized way of doing something which we all need to do all the time, which is to be able to bring our ideas and differences of opinion into collision with each other without that being interpreted as an attack on the person. And so I just really enjoyed this for that reason. We went at it, as you kind of all saw, but you didn't know what we really thought, and that's because it was in the service of the ideas rather than our personal identities.
Now they're clapping. Where were you 20 minutes ago?
There'll be no revoting whatsoever.
Different question.
So, guilty admission here. It's interesting that you all are, well, at least that Richard is in favor of national health insurance and single payer, because we spent an extensive amount of time researching your name to try and read quotes from you backing up our own point, and couldn't find any of them. Didn't know if you scrubbed your social media before the debate or what, but we were a little disappointed on that front. We feel like you should have written at least one article about your vita's really long.
I'm not a health policy expert.
Jeff and Ember, where you debated this for a year, and you just had another opportunity to do it. Where are you at on this topic?
I think it's undeniable that the single-payer systems, as Dr. Reeves discussed, that exist in the UK and Canada deliver quality health care at a much lower cost. I think that's absolutely true. I do think that there's something to be said, however, though, that the U.S. getting there from where we are now it could be quite difficult. And I think that my opinion is probably closer aligned to where the Brookings scholars were talking about the systems in Germany where we can incrementally increase the government's regulation of healthcare prices and maybe slowly get us to a system that's closer to single payer, I think.
Ember, what about you?
Yeah, I think it's probably kind of unsurprising. I'm a college student, so generally I'm in favor of something like a single payer national health insurance program. I think that it is a real problem that in this country, if you're diagnosed with sometimes a treatable disease, that you end up dying, or your family has to worry about how they'll pay for it. And I think that that's kind of like a moral issue I have, but obviously we discussed a lot of the less moral problems as well, so I won't rehash those. But I do think all in all it'd be net better if incrementally implemented.
Well, let me bring, I hate to bring this night to a close, but we want to be respectful of everyone's time, but let me do that with a question to you, Ember and Jeff. First of all, we're going to borrow that trophy back and get your names inscribed on it. And second of all, would you help me walk out of here, because I don't want my Brookings colleagues to hold tonight's results against me. And
absolutely.
Third of all, right, finally, would you be interested in a rematch, perhaps at the Brookings Institution in Washington, D.C., if we could make some arrangements?
Absolutely.
Yeah.
That you can find better colleagues that can put up a better fight.
Yeah. We'll find some opponents.
So that's what
that I assumed in my mind.
He's really got a target on his back somewhere.
A special, again, thanks to the four of you and to all of you for joining us tonight. We hope we'll see you at future Brookings Mountain West events. Have a good evening.